And you see that this can be very risky, because if this bead is not exactly of the same length, there might be a shift here. Here, you make your scan directly after the R peak. Why is that so? Important, if we just say these are the fixed delays you have after scanning, and we do not have a perfect R to R, but we have some arrhythmia or a short beat over here. This time is set, you make your scan over here. This time was also set, you make your scan over here. In both examples, you see that your scanning is right in the R peak. So there will be a lot of movement. If you do your reconstruction, you will have a lot of movement artifacts in your image. So how can we correct this? Because you only make a single scan, as over there. Now, if you do not move the scanner, you can stop your scan when the peak comes in. And this is only a very, very brief amount of exposure. Not enough to make any reconstruction. But the machine recognizes this, so this is too short, so I will try to make a scan on the second beat. And this one, you can reconstruct. For this one, because it's a fixed distance, there's no way of movement. So real-time arrhythmia rejection, looking at the beat, seeing it's too short, make a second scan, is possible here. It's not possible there, because you are at this position over the heart and you have to make your scan. In practice, this means that this scan cannot be used, and this patient, you still have a very good image quality, because you use the axial volume. So as I said, a large part of the population with cardiac disease is excluded from scanning if you use a helical approach. And these patients cannot be scanned. Irregular heart rates, extrasystoles, atrial fibrillation, breath hold limitations, higher heart rates. These are all limitations. Patients having this will not be scanned in a helical approach. In the axial volume, you can basically scan every patient, because you can correct for the irregular heart rate, which you saw in one of the previous slides. You just make a second scan. The extrasystole is no problem. Atrial fibrillation is not a real issue. And you avoid helical scanning, and you there's a reduction of the so-called blooming. You can see far more details. And the patient-controlled scanning for the atrium rejection, fibrillation. Now let's have a few examples on clinical images. These are always the proof of if this is working. Here you see a patient with a heart rate between 38 and 83 beats per minute. And still we do a single beat scan. You have very sharp details here on the left side with calcifications over here. Very nice imaging. Some very tiny calcifications. This is also very nice. And you see this in a helical approach would not be possible. If we go to the next one, it's 5296. Again, very nice. This is right coronary artery. Left side, very nice image quality. This is another example, 43 till 96 beats per minute, with a very high calcium score, 845. Why do I mention these calcium score? If you use a helical approach, very often it's said calcium scores above 600, you should not scan for coronary arteries. Here you see 845, which is far above. The right coronary artery, almost no calcifications. In the left side you see many calcifications, but because there's no blooming, you still have the possibility to look through the calcifications and see the artery. And one of the slides I started with said this new technique can be useful for non-invasive modality for investigating subjects with chronic atrial fibrillation. I showed you a few examples, but what does it mean in practice? It's easy to put just a few examples on the screen and say, this works. But if we look at the recently published paper from Uehara et al., it states here, when I compare atrium fibrillation to normal sinus rhythm, and I have highest, high and average quality, assuming that I can still diagnose these three qualities. This is for sure, and assuming this is also, then you see that the difference between this one and this one is a mere 0.5%. So atrium fibrillation can be scanned using an axial volume. So any patient you have can be put on the table. You're not so much interested in the heart rate. If you cannot correct, the scanner will correct for you. The last item I want to cover here, also with a little bit of technical detail, is first pass myocardial rest stress perfusion. Rest stress perfusion nowadays is very often done in nuclear medicine. And in nuclear medicine you can easily use radiation dose up to 20-25 millisieverts for a cardiac scan. And those scans are very often repeated several times. Here we have, with the new technology on the Aquilium 1 and in volume, you can do a myocardial perfusion in a single beat. And how does this basically work? Of course, you need two volumes. You acquire the rest and the stress study. And it looks like this. This could be, for example, if you go in a helical approach, you have a program that will automatically detect the contrast appearance in the CT. And if the contrast reaches a certain level, the system will automatically prepare for scanning and it will start the scan, which is over here. The typical delay between this and this one is 5 to 10 seconds, depending on the heart rate and the amount of motion in the helical you have to make before you can start your scan. So this is the scan start. Now what happens if you have this and you have this? This could be easily the second scan. And you see they reach the same level of contrast to start the trigger for scanning, but the contrast in the heart itself here is at optimum, and here it's only half of the optimum. If you compare these two for stress rest imaging, there would be a problem. The contrast distribution would be different from the start on. So how can you solve this one? Because you want to have an automatic trigger to be sure that you have enough contrast, but you want to also scan at the right moment. So not over here, but basically over there. Now, if you look to a volume scanner, it works totally different. Because there is no movement, you can make your scan immediately after the peak. That's what you saw in the first beat. So you scan the amount of contrast, and you make your scan, which is usually within 1 second. Because you have to wait for the R peak, then you make your scan. And in case the contrast distribution is a little bit different, your scan time will be simply later. And this one, you can compare to this one. So if this would be the stress and this would be the rest, you're still fine, or the other way around. If you go in a helical, your scan would be over here and over there. Very difficult to compare. So first pass myocardial rest stress perfusion, which would say something about the physiology part of the myocardium. In CT you can do that in a 3D display like this, where you can have an idea where you have a problem in your perfusion here, in the apex, or you can also have the classical bullseye, as many of you might know from nuclear medicine. And of course, having a CT scanner, you can also make your coronary arteries, you have the rest, you have the stress, you have the 3D, you have all options from a normal CT available, which you do not have when you do nuclear medicine. The amount of dose that you use here is usually, let's say, 50% of a myocardial scan in nuclear medicine. So in the axial volume, cardiac scanning is available for every patient. You can scan irregular heart rates. We avoid helical scanning and we reduce the blooming. We can patient control to keep the low dose. You do a single beat, low radiation exposure. Even when you do myocardial, you make 2 single beats. And you can do a low dose rest stress perfusion scan. Thank you for your attention. Any questions?
To try and put that now into context, what does it mean and what's the clinical role of all this extraordinary technology? We're privileged to have, I hope, I haven't actually seen him. Yes, I have. Duncan Diamond, who I suspect is known to many of you through his, well, high-profile media appearances. But he is absolutely wonderful at taking all of this very technical data and telling us what it really means in daily practice. Duncan.
Thank you. Thank you very much. No pressure then. Thanks. Well, good evening, everyone. Some people might say that cardiologists have no perspective of anything. They just have their blinkered view about what is right and wrong. And like many perspectives, it changes with time. So all I can really do in this evolving technology is to try and describe perhaps my view and share with you how I think this is fitting in at the moment and where perhaps we're going to go in the future in this very exciting technology. The first question, of course, is, do we actually need a non-invasive coronary angiogram? There are many of my colleagues who might think that non-invasive coronary angiogram is the worst invention ever, for a variety of reasons. But there's no doubt that in clinical practice we do see a high prevalence of what we call normal coronary angiograms, up to maybe 25 to 30%. Not only does that produce a radiation burden and an invasive burden, but also an economic burden, because it's very expensive. People have often difficulty of repeated vascular access. Right groin, right wrist, right brachial, left brachial. Where do you go next? And some cases, particularly in our older patients, there's a lot of vascular tortuosity, especially when you're struggling to find an internal mammary through a waterfall aorta up in the neck, and it can be really tiger country. There's a theory that perhaps we should be able to intervene early on graft disease. Vein grafts, when they go down, can go down very quickly, and the need for ease of repeated examination in these people. And despite other imaging techniques, no matter how good you are at nuclear medicine scanning, stress testing, or stress echocardiography, there's still patients where you have a need to know, yes, doctor, but are my arteries normal? Now, we'll see a bit later what we actually define as normal may have to change as we explore the vessel wall as well as the lumen. And there is competition, of course, in all this, from our bog standard treadmill test, which is widely available at your local supermarket, which nearly anybody can have, to nuclear scanning with MIBI, to stress echocardiography. But the problem with these, of course, is that they can be very subjective and open to interpretation. Whereas the coronary arteriogram, which has always been, as we'll see later, our gold standard, this usually is, like scissor, paper, stone, the one that wins over all the other techniques, simply because you could actually see the arteries. And we as cardiologists have been brought up for the last God knows how many years with what we call tubular cardiology, the ability to watch the passage of contrast medium through a tube and make some assessment of whether it's normal or abnormal, critical or non-critical. So what are the indications for cardiac CT? Well, obviously the first one is looking at the coronary arteries, the native coronary arteries. The second one is looking at graft studies. And then probably the most intriguing area of all is problem solving, which covers a multitude of sins, as we'll see in a minute. Well, as you've seen in the first talk, it's pretty easy to recognise a normal set of coronaries from a CT angiogram. It's actually quite difficult to get it wrong with the modern technology, with short acquisition time, larger field of view, and the not having to gate several cycles. And you can see the smooth passage of contrast. And this is incredibly seductive to look at and beautiful to explain to patients who come in with repeated episodes of chest pain. And certainly in the National Health Service, the way things run is that even if you had a normal coronary arteriogram last week, you come into A&E with chest pain, you will get an ECG and a troponin level, you'll be put on a ward, a 12-hour troponin will be done, it'll be negative, and then you'll be booked an appointment for a stress test in 6 weeks' time, And if you go out of hospital and all those are negative and you